Contrast media. Contrast media are the substances which, when used in radiographic imaging, increase the contrast between the organ of interest and the surrounding structures. Classification of contrast media. Contrast media are classified as positive and negative contrast media. In positive contrast media, we have water-soluble iodinated contrast media and water-insoluble barium sulfate. Negative contrast media are carbon dioxide, nitrous oxide, air, and oxygen. Iodinated contrast media are the water-soluble positive contrast media, and they are the derivatives of 2,4,6-triiodinatic benzoic acid, clinically classified into two groups: high osmolar contrast media and low osmolar contrast media. High osmolar contrast media: ditriazoid, iothalamide, metrizoid are the ionic monomers, and iodine to particle ratio is 1.5 and osmolality of 1500. Ionic monomers: there are ions, anions, and cations. So anions compounds are ditriazoid, iothalamide, iodixthalamide, iodiamide, and metrizoid. Low osmolar contrast media having low osmolality: iojaglate, that is Higgs-Jabrix, ionic dimer, iodine to particle ratio is 6/3, that is 2, and osmolality of 490. Ipamidol, iohexol, iopramide, iopentol, ioversol are the non-ionic monomers having iodine to particle ratio 3 and osmolality 470. Iotrolan, iodixanol are the non-ionic dimers having highest iodine to particle ratio of 6, and they are the iso-osmolar contrast media. Ionic dimers. These are the chemical structures of the ionic dimers. These are the chemical structures of non-ionic monomers. And again, these are the chemical structures of non-ionic dimers. What are the adverse effects of iodinated contrast media? High margin of safety, but still adverse effects occur, and they are less frequent, although among adverse effects also mild and moderate are very much common, and severe reactions are very much rare. So two categories for description are non-idiosyncratic, that is toxic effects on specific organs, and idiosyncratic reactions. Non-idiosyncratic reactions: vascular extravasation, cardiovascular, hematologic, nephrotoxicity, neurotoxicity, and the thyroid functions. In vascular toxicity, there may be in venous, that is pain at the injection site, pain extending up to the arm, delayed limb pain, and in arterial, sensation of heat and pain during peripheral angiography are due to the arterial endothelial damage and vasodilatation caused by the hyperosmolality. Extravasation: pain, swelling, erythema, and even the slugging of skin due to extravasated contrast media. Risks increased with the use of pump to increase the large volume, and treatment by using cold packs, elevation of the limb, systemic steroids, NSAIDs, and antibiotics are very much useful. Cardiovascular toxicity: intracoronary injection causes the ventricular fibrillation, ventricular tachycardia, asystole, sinus bradycardia, heart block, increased QT elevation, QRS, prolongation, ST, depression, and increased T-wave amplitude. Mechanism is reduction of the ionic calcium by ditriazoid compounds as they contain chelating agents as stabilizers, and non-ionic causes less disturbances. Bradycardia or asystole due to increased vagal activity, significant fluid and ion shifts due to hyperosmolar contrast. Hematologic changes: hemolysis and hemoglobinuria are the functions of hyperosmolality. increase the rigidity of the red cells, mainly the function of hyperosmolality, partly due to chemical effect, impairment of blood clotting and platelets aggregations, potential effects on the action of heparin, thrombus formation, particularly when the contrast mixed blood in the syringe is injected, sickle cell crisis, provocation, transient eosinophilia after 24 to 72 hours, nephropathy. Contrast agents related nephropathy is an elevation of serum creatinine level of more than 0.5 mg% or more than 50% of baseline at 1 to 3 days after the iodinated contrast media injection. The elevation peaks by 3 to 7 days and usually returns to baseline in 10 to 14 days. The incidence in the general population is 2 to 7%. Almost in 25% of these patients, there will be a sustained reduction in renal function, most commonly when the nephropathy is oliguric. What are the predisposing factors for nephropathy? Pre-existing impaired renal function of more than 90%, diabetes, 50%, dehydration, old ages, very large dose of contrast, multiple myeloma, and others nephrotoxic drugs. Mechanism: impairment of renal perfusion, then the cardiotoxic effects, then increased peripheral vasodilatation, increased rigidity of cells, and osmotic diuresis. Glomerular and tubular injury causes impaired perfusion, then hyperosmolar and the chemotoxic effects. Obstructive nephropathy causes cytoplasmic vacuolation on tubules and PPT of, that is precipitation of TAM, horsefall, and Ben-Jones proteins. Neurotoxicity may cross the blood-brain barrier during angiogram. So contrast media may cross blood-brain barrier during angiogram. Sodium containing more neurotoxic than meglumine containing high osmolar contrast media. Low osmolar contrast media causes less neurotoxicity than high osmolar contrast media. May provoke convulsion in patients with epilepsy or cerebral tumors. Convulsions may occur secondary to cerebral hypoxia caused by hypotension and cardiac arrest. Thyroid function. Thyrotoxicosis may occur in non-toxic goiters. Symptoms may aggravate in pre-existing thyrotoxic patients. Contrast media may interfere with TFT, that is thyroid function test. Idiosyncratic reactions, classified into 3 groups: mild, moderate, and severe. Mild reactions are those that do not interfere with examination and require only firm assurance and close observation. Mild symptoms include the following, like scattered urticaria, the most commonly reported adverse reaction, pruritus, rhinorrhea, nausea, brief itching and vomiting, diaphoresis, coughing, and the dizziness. Moderate reactions are those that interfere with the examination but do not require active treatment. Reassurance and close observation with preparedness is necessary. Moderate symptoms include persistent vomiting, diffuse urticaria, headache, facial edema, laryngeal edema, mild bronchospasm or dyspnea, palpitations, tachycardia or bradycardia, hypertension, and abdominal cramps. Severe reactions, those that interfere with the examination and require active management without which life is in danger, include the following: life-threatening arrhythmias, ventricular tachycardia, hypotension, overt bronchospasm, laryngeal edema, pulmonary edema, seizures, syncope, and as well as death. Mechanisms of idiosyncratic reactions: histamine release, complement activation, protein binding, and enzyme inhibition, chemotoxicity, and anxiety. Histamine release: contrast media causes activation of mast cells and basophils, which release histamines and produce flushing, urticaria, metallic taste, hypotension, collapse, neurotic edema, and bronchospasm. Basophils of allergic individuals release more histamine. Hyperosmolality is the major factor to cause cell activation, but even the isoosmolar agents do so. But the high osmolar contrast media have more effect than the low osmolar contrast media. Meglumine salts have more effect than the sodium salts. So bronchospasm is 4 times more with meglumine than with sodium salts. Complement fixation. Contrast agents causes vascular endothelial damage, which stimulates formation of kinins, thrombus, FDP, histamine, and hemolysis. A number of inhibitors limit the function of these agents. One of these is C1 inhibitor. Level of this inhibitor is different in different individuals and in some individuals at different time, less in reactors than in non-reactors. Low osmolar contrast media cause less endothelial damage than high osmolar contrast media. Protein binding and enzyme inhibition. Contrast media weakly bound protein inhibits enzyme acetylcholinesterase. Degree of inhibition depend on degree of protein binding. Increased cholinergic activation causes vasodilatation, bradycardia, hypotension, bronchospasm, and urticaria. Low osmolar contrast media causes less effective enzyme inhibitors. Biliary agents are more protein bound and are more toxic. Chemotoxicity. Cations are more toxic than the anions. Sodium is more toxic than the meglumine in brain and myocardium. Ionic contrast media are not used in subarachnoid space for their greater toxicity. Anxiety. Anxiety patients have high autonomic nervous activity, so contrast agents can cross the blood-brain barrier and stimulate the limbic area and hypothalamic area and produce further autonomic activity. Responsible for pulmonary edema, bronchospasm, ventricular fibrillation, and cardiac arrest, bradycardia, respiratory arrest, fever, consumption, coagulopathy, and urticaria. Risk factors for reactions. Risk factors related to idiosyncratic reactions, risk factors related to contrast-induced nephropathy, and risk factors related to non-idiosyncratic reactions. Risk factors related to idiosyncratic reactions. Previous reactions 3.3 to 6.9-fold increased risks of developing reactions compared to general population. Asthma 1.2 to 2.5 times higher risks. Food or medication allergy 1.5 to 3 times more risks. Risk factors related to non-idiosyncratic reactions. Patient receiving interleukin-2 immunotherapy for cancer and ICM increases the severity of delayed reactions. This reaction can occur even if immunotherapy is administered as long as 2 years before ICM administration. Metformin chance of life-threatening lactic acidosis is more if the patient receiving this develop azotemia. Metformin itself is not nephrotoxic, so metformin is stopped before giving iodinated contrast media until 48 hours after the injection. Beta blockers can aggravate ICM-induced bradycardia, other cardiac arrhythmias, hypotension, and bronchospasm. These conditions can interfere with the treatment, so safer method has to be considered as far as possible, as beta blockers cannot be withdrawn suddenly. When possible, IV ICM should be avoided in pregnancy. If has to be used, non-ionic agents are preferable. Prophylaxis for adverse contrast media reactions. Pre-testing. Applying contrast media into cornea or injecting 1 ml of test dose IV few minutes prior to full dose administration. Negative results doesn't preclude major reaction, and severe reaction may occur with test dose itself. Hence, this pre-test has fallen into disfavor. Pre-treatment with steroids and antihistamines. Methylprednisolone 132 mg tablet may be orally administered to 12 and 2 hours before the study, or prednisolone 150 mg tablet may be orally administered 13 hours, 7 hours, and 1 hour before the study. If the patient had a previous moderate or severe reaction, or one that included a respiratory component, and alternate studies such as sonography or MRI should be considered. Otherwise, the following may be used: H1 antihistamines, diphenhydramine 150 mg tablet orally administered 1 hour before the study. H2 histamine receptor blockers, which is optional, cimetidine 300 mg orally administered 1 hour before study, and or ranitidine 50 mg orally administered 1 hour before the study. Chance of contrast media to low osmolar contrast media is the most important factor to reduce the adverse reactions. For reduction of patients' anxiety and apprehension. Comparison between the high osmolar contrast media and the low osmolar contrast media. High osmolar contrast media have, of course, high osmolality, and low osmolar contrast media have low osmolality. Iodine to particle ratio of 1.5 in HOCM, and in LOCM it's 2, 3, or 6. HOCM are all ionic monomers, and LOCM are ionic dimers, non-ionic monomers, and non-ionic dimers. High osmolar contrast media have higher incidence of adverse reactions and toxic effects, whereas low osmolar contrast media have lower incidence of adverse reactions and toxic effects. Adverse reactions for iodinated ICM from a large study comprising 6,000 patients: mild 2.5%, moderate 1.2%, and severe 0.4%. LOCM, it's mild 0.58%, moderate 0.11%, and severe null. HOCM are low cost, LOCM are expensive. HOCM use is widely used due to their low cost. Ionic agents cannot be used in subarachnoid space, whereas LOCM use, if cost was not the factor, then the LOCM use have replaced all other ICM, and in subarachnoid space only the non-ionic agents should be used. LOCM are used in higher risk groups. Sodium and the meglumine salts. Sodium salts are more neurotoxic and cardiotoxic, cause less histamine release and hence less chance of bronchospasm, and have immediate and delayed pain at injection site is more common, so used preferably in asthmatic and allergic patients, whereas meglumine salts are less neurotoxic and less cardiotoxic, more histamine, 4 times risk of incidence of bronchospasm compared to sodium salts. It's less common, immediate and delayed pain at the injection site, and its use is preferred in central nervous system and cardiac cases, as well as in cases with volume overload. Assessment of patients before giving iodinated contrast media. History of allergies, asthma, diabetes mellitus, renal insufficiency, and or cardiac disease. Currently or recently used medicines. Possibility of pregnancy. Prior contrast agent administration. If the patient had a reaction in the past, the nature of the reaction must be determined. Also, serum creatinine levels should be determined. Treatment of adverse reactions. Most accurate severe adverse reactions to iodinated contrast media occur within 20 minutes of injection. For this reason, the patient should be monitored for a minimum of 20 minutes after an iodinated contrast media injection. Furthermore, any physician who is responsible for an imaging study that requires the use of ICM must be able to recognize and treat acute adverse reactions. Rooms in which contrast material is administered should be stocked with appropriate basic and advanced life support and monitoring equipment and drugs. The equipment should be regularly checked. Discontinue ICM immediately. Vitals, BP, pulse, respiration, O2 saturation, open IV line, O2 oxygen if necessary. Brief history including current symptoms, medical conditions, patient medication, and ABC assessment. Mild reactions are self-limited, so assurance. Moderate reactions need close observations. Severe reactions should be treated actively. Urticaria, asymptomatic, no treatment is required. Symptomatic, mild or moderate. Diphenhydramine 50 mg may be administered orally, intramuscularly, or intravenously. Severe, treatment is as above and consider adding cimetidine 300 mg by slow intravenous injection or ranitidine 50 mg by slow IV injection. Bronchospasm, mild. Treatment includes oxygen 10 to 12 liters by face mask, close observation, and 2 puffs of an albuterol or metaproterenol or salbutamol inhaler. IV hydrocortisone 100 mg. Moderate without hypotension. Treatment is as above with epinephrine 1:1000, 0.1 to 0.3 mg given subcutaneously. Repeated every 10 to 15 minutes as needed until 1 milliliter is administered. Severe. Administer epinephrine 1:10,000 milliliter slow IV injection over approximately 5 minutes, repeated every 5 to 10 minutes as needed. Laryngeal edema, mild to moderate. Treatment includes oxygen 10 to 12 liters by face mask and epinephrine 1:1000, 0.1 to 0.3 milliliter given subcutaneously, repeated every 10 to 15 minutes as needed until 1 milliliter is administered. IV hydrocortisone 100 mg. Moderate to severe, consider calling a code or intubating the patient. Consider adding diphenhydramine 50 mg slow IV injection and cimetidine 300 mg slow IV injection or ranitidine 50 mg slow IV injection. Pulmonary edema, seat of oxygen and IV furosemide. Convulsion, IV diazepam, IV mannitol if cerebral edema, IV 50% dextrose if hypoglycemia in diabetes patient. Isolated hypotension, raise the patient leg as much as possible while preparing to administer IV fluids. The Trendelenburg position can also be effective, but many radiographic tables do not tilt. Oxygen should be administered in high doses. Hypotension with tachycardia, mild to moderate. Elevate the patient legs. Administer oxygen 10 to 12 liters by face mask and IV isotonic fluid. Example 0.9% isotonic sodium chloride solution, Ringer's lactate solution. Severe or unresponsive, treatment is as above with dopamine 2 to 20 mcg per kg per minute. Call a code if no response occurs. Vasovagal reaction, mild to moderate reaction. Elevate the patient legs. Administer oxygen 10 to 12 liters by face mask and IV isotonic fluid. Example 0.9% isotonic sodium chloride solution, Ringer's lactate solution. Severe reaction or unresponsive patients. Administer atropine 0.6 to 1 mg IV. Repeated every 3 to 5 minutes as needed until a total of 3 mg is administered. Respiratory arrest, IV line, intubate and ventilate. Recent narcotics, naloxone, no responsive, nicotinamide, colic code. Cardiac arrest, immediate thumb to precordium, artificial ventilation, external cardiac massage, asystole IV line, IV bicarbonate, cardiac adrenaline, IV calcium chloride, ventricular fibrillation, IV line, IV bicarbonate, IV lignocaine, defibrillate. Unresponsive patients collect code. MRI contrast media. MRI contrast media are used in MRI to enhance the inherent contrast between the tissues. Mechanism of action: a large magnetic field density due to their unpaired electrons interact with the magnetic moments of the protons in the tissues and so shorten their T1 relaxation time and increase the signal intensity. Electromagnetic moments also cause local changes in magnetic field, which promotes rapid dephasing of protons and so shortens the T2 relaxation time. This rapid T2 relaxation produces reduced signal intensity. Classification of MRI contrast agents. MRI contrast agents possesses unpaired electron spins. The agents may be categorized into three groups: ferromagnetic, paramagnetic, and superparamagnetic. Ferromagnetic have magnetic moments which align with scanners' applied field, maintain their alignment even after the applied field is removed. The retained magnetism can cause particle aggregation and cell function interference, so unsafe for MRI contrast agents. Paramagnetic agent, the best example is the gadolinium, have magnetic moments which align to the applied field. Alignment returned to normal after gradient field is turned off, may be made soluble by chelation and hence can be used intravenously. Maximum effect is on protons of water molecules, which shorten the T1 relaxation time and causes increased signal intensity on T1 weighted images. Superparamagnetic example is the ferrite, are the aggregation of paramagnetic ions in a crystalline lattice, cause abrupt change in local magnetic field which results in rapid proton dephasing and reduction of T2 relaxation time, produce decreased signal intensity on T2 weighted images and are less soluble than paramagnetic agents, so available only as colloidal suspensions. Gadolinium, there are a number of gadolinium chelars: gadolinium diethylene triamine pentaacetic acid, DTPA, dimeglumine, gadopentate magnevist, gadolinium tetraazocyclodo, decane tetraacetic acid, DOTA, meglumine, gadoterate, dotarim, gadodiamide, omniscan, gadoteridol, and gadobutrol, gadovist. Indications of gadolinium: CNS tumors, small acoustic neuroma and spinal seedlings, demyelinating diseases, acute and chronic plaques, more accurate delineation of tumor margins from edema, discrimination of tumor recurrence from post-op fibrosis, discrimination of recurrent IVDP from post-op fibrosis, cardiac and aortic imaging. Contraindications: there are no absolute contraindications, but roughly in similar situation as intravenous iodinated contrast media. Dose: usually 0.1 millimole per kg body weight up to 0.2 millimole per kg body weight when used in low field magnets. Slow IV injection: 60 seconds for 40 kg, 120 seconds for 100 kg. Side effects: worm, pain at the injection site, seizure, strange taste, nausea, headache, dizziness, anaphylactic reaction. Gastrointestinal MRI contrast agents, easily mixable with bowel contents, palatable. Two groups: positive agents, fatty oils and gadolinium, act by T1 shortening effect. Negative agents, ferrite and barium sulfate, act by T2 shortening effect. Contrast agents in ultrasound: gas microbubbles are used, should be less than 7 micron. Ultrasound contrast media depend on the interaction between the encapsulated microbubbles and the ultrasound beam. Allow imaging of the vascular structures which cannot be evaluated even with sophisticated Doppler techniques. Ultrasound contrast area: Levovist, most widely used microbubbles of air enclosed by a thin layer of palmitic acid in a galactose solution. stable in blood for 1 to 4 minutes. Ecovist, precursor of levo-based bubbles in galactose but not palmitic acid, cannot pass through palm beds, used for tubal patency. Alvonex, sonicated air microbubbles coated with human serum albumin, used in echocardiography, survives only a short time in left ventricle, little enhancement of arterial tree. Echogen, an emulsion of dodecafluoropentane which changes its phase, converting into echogenic gas microbubbles by hypobaric activation prior to IV injection. Sonoview, an aqueous suspension of stabilized sulfur hexafluoride microbubbles. After reconstitution of the lyophilized with saline, the suspension is stable and can be used for up to 4 hours. Gastrointestinal contrast media. Water insoluble is the barium sulfate and water soluble is the iodinated contrast media and the gases. Barium sulfate. Barium mixtures. Before barium was discovered for use in gastrointestinal imaging, bismuth was used with many untoward effects because of its solubility. Barium, with its high atomic number of 56 and its insolubility in water, is a good contrast agent for gastrointestinal examinations because it is very dense and will not be absorbed by the gastrointestinal tract. However, suspending agents are required to counter the insolubility in water. There are many additives in barium mixture. Suspending agents keep barium in solution. Vegetable gums creates viscosity and suspends barium particles in solution. Carboxymethylcellulose avoids clumping of barium and aids in the dispersion of barium. Dispersing agents keep barium particles dispersed evenly throughout the suspension. Simeticone, an anti-foam agent, prevents air bubble formation. Sorbitol improves the coating qualities of barium. It is hypertonic and therefore there is a fluid shift into the bowel lumen, thereby decreasing transient time of barium in the small bowel. Particle size of barium. Particles of barium must be small to make them more stable in suspension. A non-ionic suspension medium is used, otherwise the barium particle would aggregate into clumps. 3 different sizes of barium particles. Micron, used for upper GI and colon. Colloidal, 1:10 micron, used for small bowel and colon. Variable, 1/2:40, 2 to 40 micron, used for upper GI and colon. pH of the barium suspension is 5.3, which makes it stable in gastric acid. Density of barium suspension. Density of barium suspension can be expressed in terms of weight per volume or weight per weight. Different densities of barium preparations are available for examinations of different parts of GI tract. Barium swallow is at high density 250% weight per volume 100 ml or more as required. Barium male is at SD 250% weight per volume 135 ml. Barium follow through is at pack 60 to 100% weight per volume 300 ml. Small bowel enema is at pack 60% weight per volume 1500 ml. Barium enema poorly bar 150% weight per volume 500 ml or more as required. Advantages of barium: excellent coating of mucosa as compared to water-soluble contrast and its less cost. Disadvantages of barium: high morbidity when barium is spilled into the peritoneal cavity. Subsequent CT and ultrasound rendered is very much difficult after barium examination. Complication of barium: perforation, aspiration, intravasation, impaction, and constipation. Water-soluble contrast media in GI tract are the iodinated contrast media and the gases. 2 commonly used are ipamidol, gastromiro, 61% weight per volume 300 mg iodine per ml. This is the low osmolar contrast media. Meglumine ditriazole 66% and sodium ditriazole 10%. Gastrographene 370 mg iodine per ml. This is high osmolar contrast media. Indications of water-soluble contrast media in GI tract. Suspected perforation meconium ileus to distinguish bowel from other structures on CT. Low osmolar contrast media is used if aspiration is a possibility. Complications: pulmonary edema if aspirated, not for low osmolar contrast media. Hypovolemia in children. Allergic reaction due to absorbed contrast media may precipitate in hyperchlorhydric gastric acid, not for non-ionic ileus. Gaseous agents in GI study. Carbon dioxide and air are used in conjunction with barium for double contrast effect. Air is used in barium enema. Carbon dioxide is used in the form of gas-producing granules powder to study the upper GI tract in double contrast study. Biliary contrast media. Like conventional urographic contrast media, biliary contrast media are also the triiodinated benzoic acid derivatives. Iopanoic acid, Telepac, was introduced in 1951 and later compounds were also the modifications of it. Differences occur in the prostatic group and amino groups. These agents are excreted by biliary route and no through kidneys due to the absence of prostatic groups in position 5. Oral agents, single benzene ring. Examples are iopanoic acid, Telepac, and sodium iodate, ipodate, biloptin. They come in capsule form. IV agents, meglumine, iotroxat, bilescopine is a dimer with the polymethylene chain connecting the two rings. IV agents are rarely used these days. Metabolic pathway of oral agents. Absorption from gut by passive diffusion. After absorption, albumin bound carried to liver by portal vein. In liver, taken by hepatocytes. Conjugation with gluduronic acid to form more water-soluble glucuronides. Excretion into bile is an active process which can become saturated and is the rate-limiting step. Concentrated in gallbladder by absorption of water. Peak opacification of gallbladder occurs after 12 hours of injection, and oral agents are finally excreted in stool. Reabsorption is limited by the fact that after conjugation they are no longer lipophilic. Thank you for hearing me.